All right, good morning, everyone. The presentation today, as you can see up there, is going to revolve around a lot of pulmonology and radiology. But I was just reflecting on kind of my first experience of these grand rounds, and those were as a student, where these used to take place around the bedside. So it used to be an interesting, challenging patient where one of the clinicians, typically a registrar or a consultant, would have the whole department gathered around in one of the wards, and a patient would be discussed. And it was very much clinical. It was very much around interpreting the clinical signs and trying to involve everyone in working through the case. And at the end, coming up either with a direction if the diagnosis wasn't known, which was often the case, or if a diagnosis was known, then to kind of spend a little bit of time talking about the patient and talking about the disease that had been diagnosed. And I'm thinking back, it's not necessarily something that's easy to do, even in the absence of COVID, considering the numbers of people that would now need to be congregated together. So I'm not suggesting we need to go back to that, but I do kind of like the way it used to be interactive, and that people used to be volunteering decisions, that the presenter didn't necessarily know all the answers to the questions, but at least it was an opportunity to talk about certain things. So as difficult as it might be on a forum like this, I am hoping that we can kind of do a little bit of that today. So I do want it to be as interactive as possible. For those of you who started using Teams this year compared to last year, you'll see that they've improved the platform, and so you can now see the hands and you can now see the messages while still presenting your presentation. So hopefully, again, that will also help us with respect to interacting around the case. There are some of you who will know this child either because you were involved in her care towards the middle of last year, or because I have actually presented this case twice before. Once on our pediatric, the WITS Pediatric Infectious Diseases round, which takes place on a Thursday afternoon at 2 o'clock, and I've posted the link to that in the chat, and that you're welcome. I mean, that meeting's open to everybody who thinks they can either gain something from the discussion, or if they have cases that they would like some input on from the various pediatric ID people around Johannesburg. So please, if that's of interest to you, diarize that link or keep it somewhere handy, and then you're more than welcome to join. I think they're starting again in about 2 weeks' time, so it's the beginning of February. And the other place I presented it is on the combined adult and pediatric infectious disease round, which takes place on a Monday afternoon. It's pre-COVID, it was in person at Helen Joseph Hospital, but people came from around the city to join. And now that it's online, and they'll again also be starting again probably early in February, they're a really interesting set of meetings, and it is again along the lines of collaborating and making it interactive, to be able to share experiences and share cases and share knowledge with our adult colleagues is something that I've certainly got a lot out of. And those meetings are also open to anybody who's interested in joining. And if you're interested, please let me know. We can add you onto the mailing list for the emails that go out for that. So yeah, because there's some people who may know the case, and because I want it to be interactive, so that the people, if you do know the case, and when we do start asking for input from the audience, if you know kind of the answers in advance, maybe just keep the surprise for a bit longer. Okay, and I am more than happy to take questions or comments along the way, so please feel free to put up your hand or to unmute yourself and to speak. It really is something I want to be as interactive as possible. Okay, so the case we're going to be talking about is a 10-year-old little girl. She presented on the 9th of May to our emergency department, and the history that she arrived there with, and you'll see in the next few slides, the history changed a few times, and even now, many months later, we're still not entirely sure of exactly the course of events and who was responsible for what. But at that point, she described having fallen 2 days earlier, and as a consequence of the fall, she now had a painful lump on her chest. Kind of almost incidentally, it seemed, in passing, based on the notes we have from that emergency department interaction, she mentioned that she'd been coughing for the last 6 months, and in association with that, she'd had fever and weight loss. And as a result of those findings on history, as well as the clinical findings, she was referred for admission. And then looking through the admission notes, the history that was provided to the clinicians in Ward 17 was that she tripped over a dog and fallen onto a wall, and then 2 days later this lump on her chest had developed. She also mentioned here the cough that had been noted in the ED department, but now the history is that the cough had been there for 2 months rather than 6 months. It was productive yellow sputum and was associated with systemic symptoms including loss of appetite, loss of weight and vomiting. And they reported that she had been investigated for TB in private sometime over the last few weeks, and that as far as they were aware, all of those investigations were negative. On further history, she was noted to be fully immunized. There's a comment there. There's a comment there that she had been treated by a general practitioner for boils on her back. And her social situation is fairly complicated, and I think that relates partly to why the history is a little bit unclear, and we'll come back to this aspect a little bit later. But the admission notes indicate that she said she lives with her father and his extended family. She had little recent contact with her mother, and there was a fair amount of interpersonal conflict between her parents. Our interactions with her over the next many months were largely with her family, were largely with her mother, and so that's part of the reason why we don't have an entirely clear history. Prior to this complaint and the things she mentioned on the history, she had no previous relevant medical or surgical history, and reportedly had recently tested HIV negative. She was born somewhat prematurely at 34 weeks, a little bit low birth weight at 2.3 kilograms, but apart from that, really had an unremarkable medical history up until now. She was in grade 5 and doing well, and certainly in our interactions with her over subsequent times, she does come across as a very intelligent, insightful young lady. On examination in the admission ward, she was noted to be acutely ill and in pain. She was hypoxic in room A. I'm not exactly sure what her pulse oximetry in room A was, and she was receiving oxygen. She was pale, and while her anthropometry plotted as normal, her weight of 26.8 with a weight of 26.8 kilograms, you'll see as we move through the case that there were quite marked fluctuations in her weight. Regarding vital signs, she was tachypneic with a heart rate of 160, blood pressure of 121/73. So I haven't plotted that exactly, but probably in the high normal range for her. She was markedly tachypneic with a respiratory rate of 53, and with, if anything, a low-grade fever, if not normal temperature, 37.5. The notes. The admission notes record a deformity of the right side of her chest that was overlying her 6th and 7th ribs. It was in the form of a mass, which was noted to be fluctuant, non-mobile, tender, and the clinician's conclusion at that point was that this probably represented a hematoma related to the recent trauma. In addition to that, on the same side, she had stony dullness with absent breath sounds. In keeping with the marked pallor, her jugular venous pulsation was elevated, and on cardiac examination she had a gallop and a fairly soft aortic ejection systolic murmur. Her abdomen was markedly tender, and she had a 6 centimeter, or her liver extended 6 centimeters below the costal margin, upper border. Couldn't really be determined because the whole right side of her chest was dull. That was her chest X-ray on the date of admission. Here's just a slightly better view of it, and this is where I'm going to stop and ask someone just to comment on how they would interpret this chest X-ray, not necessarily the whole case up until now, but the comments on the chest X-ray. I'd prefer not to pick on people, but if I have to, I can. And the question, might start a little easier than they're going to get. So does anybody want to just describe the pathology they're seeing? Okay, usually when we have people who shout to volunteer, we pick on the most senior person. So Ash, how would you have interpreted this chest X-ray?
All right, so it looks like the right side is almost like almost a complete whiteout, although you can see some. So it's quite a homogeneous consolidation on the right side. I can see some bronchi through that though. It looks fairly homogeneous, as I say, throughout. It doesn't seem to be shifting. It doesn't seem to. It's not causing mediastinal shift that I can see. I can't see that the trachea shifted to the left. I can't see an actual kind of fluid level because it almost looks complete, although it looks more dense lower down than higher in the lower zones than the upper zones. In terms of the mass that they're describing, there's just no indication I can see. Certainly on the like any soft tissue mass, I can't see any. The ribs to me look. When you look at the ribs, there does seem to be a difference between the ones, the lower ribs and the on the right, the upper ribs. It does seem to be that there appears to be some irregularity to the, I would say, the sort of third, fourth, and fifth ribs. Maybe it's second, third, and fourth, and that's the sort of concern to me.
Okay, yeah, I think those, I would agree with all of those, and you certainly importantly picked up on some of the subtle bony changes. In addition to what you've said, while we can see bronchi, there's possibly fairly abrupt cutoff of both the right lower lobe and right middle lobe bronchi. And yeah, as you said, there are these kind of periosteal reactions on some of the upper ribs, and then some of the lower ribs. If you could just compare the width of those to those on the other side, possibly some asymmetry. And if the last thing, just to look at the crowding of the ribs on the right compared to the left, and possibly some volume loss or compensatory hyperinflation. So volume loss on the right and possibly some compensatory hyperinflation on the left. Regarding the cardiac sound she had, I mean, her cardiac silhouette looks largely normal. And so that essentially was the interpretation of the clinicians at the time. The thinking was in line with the history of trauma, that this most likely reflected a right-sided hemothorax, and so an intercostal drain was inserted. But at that point, there was very little that came out through the intercostal drain, and I don't remember exactly. I don't think it was mentioned exactly what the fluid looked like, but it certainly wasn't what they were expecting with respect to a potentially large hemothorax. Even if it did have some blood mixed with the contents, it didn't look like frank blood as you would have expected in a pure post-traumatic hemothorax. I'll get onto her lab results later, but in keeping with the clinical finding of anemia, she did receive a packed cell transfusion over the next few hours. What you're seeing here is a repeat chest X-ray post-insertion of the intercostal drain, and so not all that different from the pre-drain insertion X-ray, so certainly not much in the way of clearing of that opacification. And she then had so I think then her radiology was reported on to some extent. So in addition to the findings that had been documented earlier, the radiology report found extensive consolidation of the right lung with what they reported as a pneumohydrothorax. And I'm not exactly sure where the air is on these forms, but that was their report, and they did note the significant bony changes with periosteal reactions in the upper four ribs, and sclerosis and widening of some of the ribs posteriorly. This abdominal pain was quite significant, and this was over the weekend, and I think the the 9th was a Saturday and the 10th was a Sunday, so it was severe enough to call out the radiologist on call. I'm guessing the concern at that stage was about this trauma that seemed to be more significant than what the history was suggesting, and possibly whether there was some intra-abdominal pathology, but the sonar was normal, but as part of the sonar they did note the fluid in the right hemithorax. Initially, she was treated with intravenous coamoxiclav and analgesia. Those are her initial lab results. So you can see a leukocytosis, which is predominantly, actually, I don't have it on here, which is predominantly neutrophils. Hemoglobin was 6, and then after the transfusion the next day, had gone up to just over 8. Platelets are normal. C-reactive protein on both of those days was markedly elevated, and her UNE was normal. So the concern right now was largely that this was predominantly, or at least acute problems, were predominantly related to this trauma, where the history didn't quite fit with the clinical presentation, and so there was understandably a concern about non-accidental injury, and also that some of those bony changes certainly didn't fit with an acute traumatic event in the last few days. But also some concern about possible underlying non-trauma pathology. TB was the one that was considered there. Okay, so next person can tell us, well, if you're the receiving doctor at the referral hospital, what would you do next in a child like this? I'm trying to think of people who don't know the patient. Willie, you never saw her, did you? Do you want to tell us what you think the receiving hospital was likely to have done? I'm moving down through the ranks of seniority. Willie, can you hear? No, doesn't seem like it. Okay, I'm not sure the reason for that. All right, going through my list in no particular order. Azra, your name's up. I think that might be because it's alphabetical. What would your approach have been at that time?
I think a CT chest would be helpful.
Okay, and what are you looking for on that CT chest?
So there's some chronic changes with the ribs, and there's a mass. So I think you'd be worried about either a non-benign lesion or some kind of a. I do know the case, just by the way, but a non-benign lesion or some kind of chronic process.
Okay, and yeah, I think that was the concern, and as you can see, the CT chest was the next major investigation that was done. And just in advance, I want someone to kind of comment on the CT chest. Let's leave the consultants alone for a bit. First registrar's name that I see here is Kath Flack. Kath, so have a careful look at the CT. There are 2 videos. I'm going to play the first one and then the second one, and we can come back to the first one if you need to. But just tell us what you think based on the CT. So the CTs were recorded off a monitor and was on a cell phone, so there is some background noise. You can ignore that.
Is it playing? No.
It's playing for me.
Oh, it's not playing for us.
It's not playing for us, Gary.
That's very weird. It did yesterday when I practiced this. Yeah, I can see that it's not playing. Just give me a sec and see what I can do.
We can just hear the sound. We can hear the background sound.
Yeah, no, I can see that. I've got it on my phone, and I can see that it's kind of...
Nicola commented in the chat that we can play the video ourselves, so we can all just press play.
Oh, okay.
Oh, thanks. That's a good idea.
I'm trying that on my phone, and that's actually not working for me. But is it working for others?
Okay, for me.
Sure, it's not working for me.
Oh, and now someone's taken control and stopped the presentation. Okay, never
Okay,
mind.
maybe that's me.
Let
Sorry
me get
about
it
that.
back. It's okay. It's
Sorry.
okay.
Control freak.
Okay, so just reopening.
So Gary, I must say that the slides that you had just after the X-ray weren't coming up. I don't know, at least for me, I don't know for others. You know, just had the X-rays and not these other slides that you put together of describing the case.
I'm not sure what you mean, but let me just try and get there. I don't know what's happening. It keeps going backwards, even though I'm going forwards.
Yeah, I mean so a couple of slides I managed to see, like these ones, but not the earlier ones where you describe the anthropometry. But maybe it doesn't matter. Anyway.
Okay, let me just do this the old way. My apologies for this, guys. All did work yesterday. Okay, is it playing for anybody now?
Yes, it's playing.
Okay, thank you.
Yes.
All right, Kath, so back to you. Look at it carefully and then we'll take it from there. That there's the intercostal drain that you just seen going past. Okay, we're going to, this is the next one. This is the lung windows. Actually, hold on. No, this is the same one again. This is the lung windows here. Okay, Kath, what are your thoughts on those two videos? You're still muted. Okay, go ahead.
Okay. Yeah, sorry, I'm unmuted. Sure. This is really impressive loss of the right lung completely. You can't really see any reasonable lung markings on either of those videos on the right, except for large airways. I wasn't sure if there was some area of breakdown as well higher up on the initial video. But I must be honest, I was a bit too distracted looking at the right to comment on the left.
Okay, I keep talking. I'm just running through them again so we can have another look.
Yeah.
So yeah, there's a dense consolidation of that right lung. You're right about that. Anything
Yeah.
else?
It looks solid
Mm-hmm.
and non-vascular.
Mm-hmm.
Um,
Anything on? I've paused it, and anything on this view that might add to what you said?
It's not involving the heart.
Mm-hmm.
Seems to be outside of the pericardium. I'm not sure.
Okay, so what you're seeing here, if you look anteriorly, because there is quite a lot of pleural fluid also here, but you can actually see it extending out from beyond the pleural space into this area where this mass is that she had. Okay, and then I think just in the interest of time, we're going to just maybe move on a bit quicker, but also some of the bony changes that were seen on the previous film. There's the chest drain that's gone by there, and then a little bit earlier you saw some of the sclerotic changes and periosteal reactions on the bones. Okay, on the lung windows, it shows essentially the same thing, and there are some lymph nodes, but nothing too dramatic. Okay, so the report on the CT chest that we've just looked at showed florid periosteal reactions of the posterior ribs all the way down from rib 3 to rib 12. In the initial CT report, mentioned multiple fractures, but I think on revision within radiology, they revised that report to say no, there were no fractures. And obviously this is important related to the possibility of non-accidental injury. They also commented on rim enhancing collection quite low down T11, T12 in the right paraspinal muscles, a number of relatively small enhancing mediastinal nodes, dense consolidation at right, and the findings that we mentioned around the pleural space, and concluded that this was an empyema necesitans. We'll come back to that point, but that essentially refers to what we saw, so extension of the pathological process from the pleural space outwards. And just to think about what the possible causes of that might be. The skeletal survey, again, in line with the possibility of non-accidental injury, showed no new pathology. The intercostal drain itself didn't seem to be doing much. Even on the previous X-ray, at least one of the holes wasn't in the pleural cavity, and on the CT scan, they were concerned that it might even have ended up in the liver. But because of all consolidation, they couldn't really see where the diaphragm was and where consolidated lung ended and liver started. It hadn't actually, but that was a concern, and so they understandably removed that. And they involved a number of others at that time. So the ped surgeons involved, the child abuse services through the Teddy Bear Clinic, pulmonology and general peds were involved. Now all of them were apparently involved, but the involvement, it seems, as you'll see over the next few slides, was somewhat peripheral. And then she was transferred back here after having been there for 5 days. The reason for transferring her back was for stabilization, which was a little confusing to us, as she seemed, as far as we could tell, stable. She'd come off of oxygen. She was fully mobile, fully alert and orientated. But in any event, she did come back here. And the plan at that point was for her to go back there in a few days for a pleural biopsy to try and figure out what was actually going on. The lab results that I was able to find from Joburg show really not much change. White cells remain elevated, hemoglobin a little bit lower, but not dropping particularly fast. Platelets remain normal, uni remained. Platelets remain normal, uni remained normal. Back here for those few days, antibiotics and analgesia were continued. The date that we were going to transfer her back, I think there were no beds available, so the pleural biopsy was delayed until a few days later, and then she went back there on the 21st of May. In her time here with us, again, not much change from a laboratory point of view. Her white cells remain elevated. Hemoglobin actually seemed to be improving. CRP maybe had come down a little, had come down a little bit, but still remained quite markedly elevated, and the rest of those results were normal. Just in the interest of time, I'm going to move on to her additional investigations, but the number of problems that we've touched on were investigated further, and these are just some of those investigations related to the various things we found. So because of the abdominal symptoms, lipase and amylase were done, which were normal. Because of the cardiac findings, troponin was done, which was normal. Because of the anemia, iron studies were done, which were predominantly really in keeping with an anemia of chronic disease more than anything else, with an elevated ferritin and everything else being low. Liver function tests were essentially normal, but she did have a fairly broad globulin gap and a slightly low albumin. LDH was mildly elevated. Haptoglobin was not low, was actually high. And keeping in mind the possibility of a non-benign lesion, alpha-fetoprotein was normal, uric acid was normal, calcium, magnesium, phosphate was normal, and HIV lyso was negative. Along the lines of investigating her for TB, over the course of the time, both prior to referral at the other hospital and back here, a number of respiratory samples were collected. I couldn't even try. I didn't really try and count how many there were, but all of them had sputum experts that were negative. The pleural fluid itself showed fairly non-specific changes. Some neutrophils, gram-positive bacilli were apparently visualized, but culture was negative. And all those samples subsequently over the next few weeks came back culture negative. She then had this chest x-ray done on referral back to the pediatric surgeons prior to any surgical intervention. And really, I mean, we don't have to spend too much time on it, other than to say it's largely unchanged and quality-wise not as good as the ones that were done here. And this is, I think it's going to take a kind of step sideways for a bit, and just want people to recognize just how good the radiology and particularly radiography services are that we get here, and just to look at how, looking all through all these x-rays, how the quality of the chest x-rays done here are so dramatically better than the quality of the x-rays done in the other department. And we do need to acknowledge that. But essentially this shows that right-sided consolidation, and not much else that we can comment on there. Lab investigations, again, not real changes here. White cells remain elevated, HB continues to improve slowly, platelets have gone up a little bit, but that's fairly non-specific, and that drop in CRP seems to have reversed, but this was around about the time of the surgery, so the elevation in the CRP between the 22nd and 25th may actually have been related to the surgery rather than to any ongoing pathology itself. They attempted a thoracoscopic biopsy, but that was unsuccessful, and so she then went into she then went back to theatre on the 25th for a thoracotomy and biopsy, and then a day or so later, we're not exactly sure how the timing around this, but she was discharged, and as best as we can tell, because it wasn't discussed with us at that point, she was discharged without any medication, and again, as far as we can tell, without any real discussion with pulmonology and general peds, although they had been included initially. This was her chest x-ray just prior to discharge, and again you can see that no new pathology there, but no real improvement. Not exactly sure the course of events over the next few weeks, but she did return for a pediatric surgical follow-up date that she was given early in June, so this was probably a week or two after her discharge. Exactly what took place at that visit, I don't know. As part of that visit, peds pulmonology were consulted, but it seems that by the time they were able to speak to each other, surgery and pulmonology, the patient and her mom had actually left, and it didn't seem that too many changes were made at that point. Obviously, from our point of view, we were interested in and not really sure what was happening with this child, and so possibly fortuitously checked her histology results here. The results had just been authorized, and I'm not going to reveal that result just yet, but based on that result, we contacted the patient again. She was given the option of being readmitted here or back at Joburg, and their preference was to come here. So she was readmitted on the 19th of June. She spent 4 weeks here. When she got here, initially her weight had dropped. It was 5 kilograms below that first admission weight. Those 4 weeks in hospital were, at least from a medical point of view, relatively unremarkable. In other ways, they were quite trying, both for her and her mom and the nurses. There was a fair amount of friction between her mother and the nursing staff, and on a number of occasions we had to kind of placate her and convince her to stay in hospital and not go home. And the last time I saw them was mid-September, and By that point, she was doing very well. She was asymptomatic. She picked up 8 kilograms from her lowest weight. And then I'm not entirely sure if she missed her follow-up date in November. I contacted the mom recently, and she said they did come here. They were seen by somebody, but were told I wasn't around. And I can't find notes of that visit. But in any event, we rebooked her for early next month. Her lab results, she, on readmission, so that's that last column you're seeing there, that her white cells were lower, her HB was now normal, and her CRP was actually relatively low, even despite the fact that she hadn't actually been on any treatment. So before we kind of reveal the answer, which was obviously on the histology report, does anybody want to hazard a guess as to what it might have been? Yeah. Anyone?
Well, clearly it's not malignant.
Yep. So we can confirm it wasn't malignant and it's not TB. Any other ideas? Okay. So it certainly came as a surprise to us. So no shame in not coming up with the answer. But on the histology report, and I've just taken a piece of it out here. They saw eosinophilic rod-like structures demonstrating the Splendor-Hoopley phenomenon. On special staining with Grocott and Wharton-Starry, filamentous branching rods were seen. They were gram-positive and PAS-positive on further staining, and the final conclusion was that of actinomycosis, which, looking back, and we'll go through some of the discussion now, fits very, very well. But wasn't something that I think anybody had seriously considered up until that point. So just to go through some of the histopathology related to that biopsy, and what you can see here is, and these slides are from Cheryl Ngwenya from the Department of Anatomical Pathology. So what you can see, the arrow pointing to there is the severe expansion of the tissue with inflammatory changes, and the arrows showing you a grain or a granule on fairly low power magnification. This shows the same or another granule on a higher power. And the arrows there are, the blue arrow, the top arrow is shows the surrounding cuff of neutrophils, and the lower arrow, the black arrow, shows this kind of bluish appearance of the tissue, which is apparently related to the organisms. This is again the same granule, but at higher magnification. You can again see the outer neutrophilic crust. You can see the bluish center related to the organisms, and these eosinophilic rod-like structures. I don't know how well that you see it on this picture. I'll show you some of the subsequent ones where with special stainings it's more obvious. But radiating from the edge and interdigitating with the surrounding acute inflammation. This is just showing the kind of general background tissue inflammation. Here what we're looking at is a non-H&E slide. This is a PAS stain. And the purple discoloration indicates that the organisms are PAS positive, so that they're taking up the stain, which is characteristic, or one of the characteristics of a number of organisms, including actinomycosis. And then possibly where you can see them best, this is the Brown's hop stain. Don't ask me exactly what that means, but you can see here all these purplish organisms, filamentous branching, gram-positive organisms in the middle of this granule. And then finally, from the histopathology point of view, the Grocott stain showing kind of in black on a green background all the branching filamentous bacteria, and on the Wharton-Starry stain showing essentially the same thing. These are all just different stains, which depending on what stains are taken up by the organism, can give the pathologist some idea of what they might be dealing with. None of her samples were actually culture positive, so the diagnosis was purely based on the histology. Moving through quite quickly, just the last little bit of radiology. On readmission here on the 19th of June, this was her chest x-ray, so that you can see that despite being off treatment for a number of weeks, the x-ray was was improved compared to her baseline. Certainly quite a lot of pathology going on. Again, all of that on the right side, but less dense and less consolidation. Obviously still the rib changes. And the next X-ray, this was kind of halfway through that final admission, where she'd been on treatment for a couple of weeks, and you can see that there's ongoing continued improvement. Still a fair amount of pathology, particularly what you can see on the lateral, but that right upper and right middle lobe areas are certainly clearing, and even some improvement to the right lower lobe area. The last time I saw her was on the 15th of September, and unfortunately these are the only photos that we've got of her actual chest wall. Her mom said they did take some photos, and it seemed that whoever had taken the photos on their phone had deleted them in the course of time, and so I don't actually have pictures of the original anterior and posterior wall chest masses. But what you can see here, just looking laterally, the large scar from the thoracotomy with additional scars from the where the drains were inserted. Looking on the top right, an area of hyperpigmentation where the anterior chest wall mass was, and then looking at the back, these kind of boils that the GP had treated, almost certainly part of the same inflammatory process. And you can see, again, some post-inflammatory changes on her back. Her chest X-ray on that date is shown here. So this was now after about 3 months of treatment, and again there's ongoing improvement, still a fair amount of pathology, still some volume loss on the right, still some pleural changes, but markedly improved parenchyma, and on the lateral certainly quite dramatic improvement on the lateral compared to the one before that. Okay, so in the last few minutes, just quickly go through a couple of aspects. So firstly, Empyema necesitans. So as we mentioned earlier, this refers to the extension of a pleural infection outside of the thorax and into the neighboring chest wall and surrounding soft tissues, which you could see quite well on that CT scan. Why does it happen? So why does it sometimes happen that there's pleural pathology that extends beyond there, and partly related to the virulence of the organism? Sometimes it's related to tracts being created either through surgery or other forms of trauma that allow the infection to spread, and it can pretty much go anywhere. Most classically to the subcutaneous tissues of the chest wall, but it's been reported to involve esophagus, breast, into the retroperitoneum, the peritoneum itself, pericardial, paravertebral, so almost anywhere. And kind of, at least in the classic cases, the subcutaneous involvement can rupture through the skin and discharge, which we think was probably close to where she presented. If the pathology had been allowed to progress any further, that's likely to be what would have happened next. The causative organisms, and looking back, this is obviously a search that we should have done sooner, because our thinking was, and certainly the only cases, and there haven't been many that I've seen, but the only ones that I have seen up until now have all been TB, and so the thinking was largely that this was TB, and that is true for more than 2/3 of cases. But number 2 on the list is actinomycosis. There are a few others that also cause this or have been reported to cause this: blastomycosis, aspergillus, nocardia, mucor, and fuso. But clearly between actino and TB, you're going to account for the vast majority of cases. On radiology and plain X-ray, fairly non-specific features that can even be normal at times, and you may, again, if there's subcutaneous involvement, have a soft tissue density in the chest wall. CT is the most appropriate and most useful investigation, which assesses the extent of the infection outside of the cavity, and classically shows an empyema with extension through the chest wall into an extrathoracic compartment, and accompanying rib destruction, as we saw in our child, is not uncommon. The management may include either closed or open drainage, but the mainstay is antibiotic therapy, and certainly, depending on the cause, may be all that's required. The differential diagnosis, again, much along the lines of what we were thinking here, is a pleural-based malignancy or transdiaphragmatic spread from an infection somewhere else, either intraparenchymal or from outside. Typically, the abdomen would be an important place to look. Actinomycosis is, so that's all the discussion I've included here on Empyema necesitans. Moving on to actinomycosis. The word itself means ray fungus, but it's not a fungal infection, it's a bacterial infection. It causes subacute to chronic pathology. The organisms, as you've seen, are filamentous, so they're kind of fairly long and thin. They stay gram-positive, non-acid fast, and that's important when you're differentiating it from some of the other organisms on that list of possible causes, and is anaerobic to microaerophilic. Classically spreads via contiguous spread, to adjacent structures with both suppurative and granulomatous inflammation, and fairly commonly with multiple abscesses, as we saw in our child with sinus tracts. They may discharge sulfur granules, so if it breaks down and opens up to the chest wall, it can discharge these kind of classic yellow granules, which are just colonies of the organisms, really. The most common forms are cervicofacial, thoracic, which our child had, and abdominal, and in women, pelvic actinomycosis, often related to intrauterine contraceptive devices. It's also possible. A little bit more about the microbiology. They're non-spore forming. There are at least 25 separate species. The majority, or at least the most important one, at least from a human point of view, is Actinomyces israelia, but you can see a whole bunch of others listed there. And as people are starting to do more and more molecular work on them, they're realizing that there probably are a number of other separate species. In addition to Actinomyces, there are other organisms, Propionibacteria, Actinobaculum, and Bifidobacteria, that can be fairly similar from a laboratory and to a lesser extent a clinical point of view. They grow quite slowly in anaerobic or microaerophilic conditions, and when they are able to grow, they form a fairly characteristic colony with molar tooth appearance. And this, for me, was one of the most interesting things in reading up about actinomycosis, which I didn't know before, in that they're largely non-pathogenic by themselves, but when they're companion bacteria, they work synergistically to result in more severe and more virulent disease. And some of those companion bacteria, and it can be a combination of these or one of these with actinomyces, but together they're responsible for more progressive disease. They are part of our normal oral flora. They are predominantly in the mouth, but they can feature to a much less extent in the lower GIT and female genital tract. They are of low virulence by themselves, and so they do require some brachimucosal integrity and devitalized tissue in order to start causing pathology. As I said, they're often polymicrobial, and there can be a number of different organisms, species of organism implicated. And they're able to cross tissue flames because of the intense inflammatory response. Going through just fairly briefly the various different types. First of all, cervicofacial. This is the most common type, making up a half to 2/3 of cases, classically in association with poor dental hygiene or following oral surgery, and there's swelling around the perimandibular area that over the course of the next few weeks results in fistulae, sinus tracts, discharging paramaterial, and if untreated can actually involve cranium or spread more broadly through the bloodstream. Thoracic actinomycosis occurs in about 15 to 20% of cases, usually following aspiration of oropharyngeal secretions, occasionally following esophageal perforation. Presents as like our patient with a pulmonary infiltratal mass that can then spread to involve pleura and then anything else from there, including pericardium, chest wall, and then sinuses with draining granules. Abdominal or pelvic actinomycosis makes up the minority of these cases, classically following bowel surgery or foreign body ingestion. Can present as a slow-going ileus. Epidemiology, it's globally distributed but rare, and the incidence seems to be declining, probably related to better oral hygiene. Mortality and morbidity is certainly much, much lower than it now than it was in the past, largely related to antibiotics, and death or deformity is actually uncommon. There appear to be no racial predilections. There's a 3-to-1 predominance of males over females, except for pelvic disease for obvious reasons, and the reason for the male predominance is not entirely known. Can affect anybody at any age, but the classic age group is kind of young adults between 20 and 50, but it's well described in children. Regarding laboratory studies, like our patient, anemia and leukocytosis are common. Inflammatory markers, including CRP, are often raised. The organism identification can be identified directly or on isolation from clinical samples or from a sulfur granule. It does require prompt transport, preferably in an anaerobic transport device. The organisms may be seen on gram staining. Anaerobic cultures need to be incubated for at least 48 hours and sometimes longer, and it can be quite difficult to for the lab to give a definitive identification. It's not always necessary because the antibiogram is quite predictable. They're seldom resistant to first-line antibiotics, and non-kind of culture-based techniques are under development. This is just a histology slide to show you the organism, but this is essentially what you're already seeing from our patient, and you can see those in this stain, those central bluish purple filamentous bacteria. The treatment is with antibiotics, initially parenteral antibiotics, and that's the reason why we readmitted her for the 4 weeks of intravenous antibiotic therapy, and then prolonged courses of oral antibiotics. The drug of choice is penicillin. Unfortunately, as you know, it's seldom available to us these days, and so we had to give an alternative. Surgery is sometimes required, but most cases is not necessary, but should be considered if there's a poor response to medical therapy. In our child, you'll remember she got that initial co-moxiclav. We don't exactly know how long, but during her initial admission between the two hospitals, she got probably somewhere in the region of 2 weeks, which would have been effective, but then her antibiotics were stopped. But by the time she was readmitted already, her X-ray was improving, inflammatory markers were down, so it's likely that antibiotic therapy was to some extent effective. She got a month of ampicillin here and then completed at least 5 months of amoxicillin after that. I'm not exactly sure when she stopped because I didn't see her at her last follow-up visit. And then this is just to kind of show you the progression in her X-ray. That was the original one, morphing into the most recent one that we have. Thanks, everyone. I know we've got only a couple of minutes left, but I'm happy to take any questions that people might have. Okay. Ash, you're unmuted. Go ahead.
Yeah, I just wanted to know whether, sorry about that, just wanted to know whether you think that there was, I mean, any predisposing factors in her that might have led her to develop this infection.
We don't know. Certainly, we've discussed this, and I mean, I've kind of simplified the whole presentation in that, at least from the non-accidental injury point of view, in that she consistently denied anything like that to us. But at some point, it seems she may have said something about her father having kicked her, but then later on denied that, and we were unable to get anything out of Teddy Bear Clinic or Joburg Hospital social workers. And we saw no reason, either from her interactions, from what she said to us, her interactions with her mom, and what she said about her dad, to suspect that there was necessarily anything to suggest physical abuse. Was there some traumatic event? Quite possibly. We've debated, should we be looking for some sort of primary or other secondary immune deficiency in her, and the plan at this stage was to, well, let's get her over this and then see what happens. For now, this is the only infection she's had, and while it is a highly unusual infection, it has responded appropriately to treatment, and she's never had anything before, and so far nothing since. So we haven't yet worked her up, but my own feeling is that if we were to, we probably wouldn't find any underlying immune deficiency. And none of the kind of classic ones present with this as a standalone manifestation, at least as far as I'm aware.
Okay, thank you. Very nice presentation. Thank you.
Anyone else? Okay, then thanks everyone for attending and for contributing. And as usual, have a good weekend, and the recording will be available in the usual Dropbox site sometime later today.
Thanks, Gary.